This video is on the COVID-19 pandemic and the social inequalities faced in India, especially in the healthcare sector. Though India's leaders have promised coronavirus testing and care for all who need it, regardless of income, treatment options are as stratified and unequal as the country itself. Care ranges from crowded wards at public hospitals that some worry will make them sicker than if they stayed home to spacious suites at private hospitals that only the wealthy can afford. Under India's healthcare system, everyone should be able to receive either free or highly subsidized care at those public hospitals depending on their income. But the system has been chronically underfunded, meaning government hospitals are overburdened and the patients often face days-long wait for even basic treatment. All this has an underlying effect of income inequalities faced, especially during this COVID pandemic, which will be touched upon after a few minutes. World Health Organization data shows that India's government spent about $63 per person on healthcare for its 1.3 billion people. By comparison to its neighbor China, however, spent about $398 for each of its 1.4 billion people in 2016. Though India has managed to halve its poverty rate for the past 15 years, some 176 million people still live on less than $1.9 a day. And experts say the pandemic is shining a spotlight on the country's vast inequalities in everything from unemployment rates to healthcare. Moving on to the general disparities and the general inequality faced by the citizens of the nation, let us begin with healthcare. Access to timely and affordable health services varies considerably for people over the world. In India, however, there are significant inter- and intrastate disparity. Rural-urban differentials are also severe. For instance, there is a huge skew in the distribution of doctors working in urban and rural areas, with the urban to rural doctor ratio being 3:8:1. In terms of availability of hospital beds, states like Bihar are well below the national average of 0.55 beds in the public sector per 1,000 population. These differences are partly because health is a state subject, and while the union government has an important role to play, every state is free to determine the priorities with respect to health financing and infrastructure. The union government is of course doing its bit by providing supplementary resources as well as offering free testing and treatment for COVID-19 up to 50 crore rupees beneficiary of the Pradhan Mantri Jan Arogya Yojana. What is not being noticed is the rural sector that has been affected the most during this COVID pandemic. The current global pandemic of COVID-19 necessitates a public health strategy with more emphasis on epidemiology, especially with regards to understanding the causes as well as identifying appropriate population-based behavioral and educational programs. It is particularly a threat to a country like India, where 65 to 68% of the population live in rural areas and having the highest overall burden of disease globally. The Indian rural sector, however, is a three-tier system comprising of sub-centers, primary health centers, and community health centers. There is currently a shortfall of health facilities, 18% at the sub-center level, 22% at the PHC level, and 30% at the CHC level. Although the number of facilities has increased over the years, the workforce availability is substantially below the recommended levels as suggested by the World Health Organization. Rural India has 3.2 government hospital beds per 10,000 people. The healthcare systems and services in India are still developing and have challenges of workforce shortages, absenteeism, poor infrastructure, and quality of care. Despite the National Health Mission and the government's commitment, adequate and affordable healthcare is still a mirage. The state of Uttar Pradesh has a 2.5 bed per 10,000 population, which is the biggest state in India. Maharashtra, however, which has seen the largest number of COVID-19 cases, however, has 2.0 beds per 10,000 population, and Bihar being the lowest, as mentioned before. We still do not know the real statistics of the epidemic in rural areas. The country is at a tipping point and we do not know what direction it will take. Now moving on to the income inequality faced, which is a general outlier in all of this, let us look at the PLFS, or the Periodic Labour Force Survey of India in 2017 and 18. 41% urban households comprised of salaried employees or those who earned regular wages. 32% households were dependent on self-employment and 11.8% earned their income from casual labor. At the outset, a large share of salaried and employed workforce should not be troubled by the lockdown. However, significant inequality exists among regular wage earning and salaried employees. According to the PLFS 2017 or 18, 71% of regular wage salaried employees had no written job contracts. 54% were ineligible for paid leave and almost 50% were ineligible for social security benefits. In this situation, however, most people will not earn a salary for the days they are not unable to come to work. Daily wage earners and those in the informal sector will be affected disproportionately. To make matters worse, this pandemic has happened at a time of global slowdown, and the public health crisis of this magnitude is likely to have an additional negative impact on the economy. and the growth rate will go down and more people will lose their jobs, thereby enhancing the income inequality.
There is a need to build a disability inclusive response to COVID 19. There remain certain sections of society that have been inadvertently excluded. Persons with disabilities or PWDs, more than 1 billion in number globally, are one such group. This is because much of the advocacy on how to stay safe during the pandemic has not factored in the inability of people who are immobile or living with mental illness to follow these instructions. Containment measures such as physical distancing and self isolation may be impossible for those who rely on the support of others to eat, dress, and bathe. The World Health Organization issued a document highlighting this issue and explaining how PWDs may be at a greater risk of contracting COVID 19. Some of these include PWDs who require additional support may find it difficult to practice physical distancing, and many caregivers may be reluctant to provide their services due to contagious nature of the novel coronavirus. People with intellectual impairments cannot be expected to cope with self-isolation, and the ones with visual disabilities rely on touch functions for mobility and work, thereby increasing their risk of infection. Public health information remains inaccessible, which acts as a barrier, particularly for people with hearing impairments. PWDs may be at a greater risk as people with underlying health conditions, particularly those related to respiratory function, immune system function, heart disease, or diabetes, are more likely to be infected with COVID 19. The situation is no different in India, where 2.21% of the population, or 2.68 crore people, are officially recognized as PWDs. They are vulnerable to the virus because of their physical, sensory, and cognitive limitations. These limitations come in the way of their capacity to access, interpret, and use the information and services being made available to deal with COVID 19 and can lead to further marginalization. The Department of Empowerment of People with Disabilities, or DEPWD, recognizes that PWDs are more vulnerable to the virus because of their physical, sensory, and cognitive limitations. The actual impairment of the guidelines, which includes Ministry of Social Justice and Empowerment, which has mandated that under the Rights of Persons with Disabilities Act 2016, department in the states and union territories should disseminate information on COVID-19 in audio formats and braille, but the implementation shows little or no progress. Healthcare during COVID-19 is also creating a gender divide in India. As opposed to 36 minutes in the case of men, women spend 6 hours in unpaid care responsibilities in a household. These gendered responsibilities further amplify during health crises. The current coronavirus outbreak necessitates maximum care for higher risk groups like children and the elderly, resulting in social distancing measures like the closure of schools and childcare centers. This forces women to devote even more time to housework. However, the current policy formulations around care work fail to take cognizance of this disproportionate burden of care responsibilities on women who are more likely to come in contact with the COVID-19 virus. The Social Distancing Advisory issued by the Ministry of Health and Family Welfare encourages working from home but falls short of mandating corporations to ensure support in the form of paid leaves to women involved in urgent care work. Currently, the hardest hit industries are aviation, hospitality, and retail, which coincidentally are also some of the biggest employers of female workforce. In India, where women's income is an abysmal one-fifth of their male counterparts, the COVID-19 pandemic has disincentive effects on women's economic participation and employment opportunities. The female workforce also figures predominantly in vulnerable jobs in the informal sector like domestic work. In India, the nurses and midwives constitute of 83.4% female health workforce who provide palliative care to the sick and infirm, and in the absence of medical doctors deal with emergencies firsthand. They, along with the accredited social service health activists, are at the frontline of COVID-19 pandemic, tasked with educating people at the grassroots level about the disease. However, their jobs are overlooked as an extension of gendered care roles and receive little attention in the terms of fund allocation, training, and fair pay. Moreover, the concentration of the female workforce in nursing does not translate to higher levels as allopathic physicians and surgeons at a mere 16.8%. Discrimination in access to healthcare aggravates when the public healthcare system fails to meet the medical needs of women. Among many unmet needs, 37% of women cited a lack of female health providers as a hindrance to their treatment. In conclusion, the pandemic of COVID-19 has necessitated the need for attention to the underserved and marginalized population holistically to prevent long-lasting adverse health outcomes. Economic stressors on the whole population will need mitigation, and quick changes in policy would help. Finally, national health programs for communicable and non-communicable diseases must be revitalized and strengthened. Apart from firm economic measures, all national health programs should be re-strengthened to avert possible surge of communicable, apart from COVID-19 that is, and non-communicable diseases. These efforts should be focused on population belonging to low socio-economic status.